Buenas noches a todos y bienvenidos a esta sesión online sobre COVID-19 y enfermedades reumáticas organizada por la Unidad de Investigación del Colegio Mexicano de Rheumatología con el apoyo del Comité Ejecutivo y personal del colegio. Soy la doctora Desiree Alpiza Rodríguez, coordinadora de la Unidad de Investigación del Colegio Mexicano de Rheumatología. La pandemia por COVID-19 nos ha impuesto muchos retos y nos ha mostrado que vivimos en un mundo que está totalmente interconectado. La frase "el leve aleteo de las alas de una mariposa se puede sentir al otro lado del mundo" ha cobrado sentido. Y nuestra vida está llena de incertidumbre. Pero esta incertidumbre, particularmente sobre el efecto de la pandemia en pacientes con enfermedades autoinmunes y reumáticas, ha dado pie a la realización de múltiples estudios de investigación alrededor del mundo. Prácticamente esto ha seguido el ritmo de la expansión de la pandemia. Tengo el placer el día de hoy de presentarles esta sesión cuyo fin es analizar algunos de los temas más importantes alrededor de COVID-19 relacionados con enfermedades reumáticas. Y para esto tenemos la participación de 3 excelentes investigadores. Primero, se abordará el peligro que representa COVID-19 para los pacientes con enfermedades reumáticas. Este tema será presentado por el profesor Axel Fink, quien dirige la investigación clínica en la División de Reumatología de la Universidad de Ginebra y preside la Comisión Científica de la Cohorte Suiza de Artritis Reumatoide. Sus investigaciones incluyen la identificación de factores de riesgo modificables en la artritis reumatoide, el impacto de las intervenciones terapéuticas tempranas y la identificación de fases preclínicas de esta enfermedad. Nuestra segunda plática está a cargo de la doctora Juanita Romero Díaz, quien hablará del tema lupus eritematoso sistémico y las expectativas ante la nueva era del COVID-19. La doctora Romero es reumatóloga adscrita al Instituto Nacional de Nutrición Salvador Subirán en la Ciudad de México y miembro del grupo SLIC. Sus líneas de investigación son epidemiología y comorbilidades en pacientes con lupus eritematoso sistémico. Por último, el profesor Wallace hablará sobre una importante iniciativa en la que México, a través de la Unidad de Investigación del Colegio Mexicano de Rheumatología, participa. Esta iniciativa es la Alianza Mundial de Reumatología COVID-19, que es un esfuerzo de la comunidad reumatológica internacional para mejorar la atención de nuestros pacientes con enfermedades reumáticas en la pandemia. El doctor Wallace es profesor adjunto de medicina en la Facultad de Medicina de Harvard y reumatólogo e investigador de la Unidad de Reumatología y del Programa de Epidemiología Clínica del Massachusetts General Hospital. Después de cada presentación, pueden escribir sus preguntas en el chat, con el formato indicado en la invitación. Después de la última presentación, se darán 10 minutos extras para preguntas y respuestas a través del chat también. El profesor Wallace y la doctora Juanita Romero contestarán las preguntas directamente en el chat y por el horario al profesor Fink se le enviarán las preguntas por correo electrónico y él contestará posteriormente. Agradecemos sinceramente a cada uno de los ponentes por su participación, al profesor Axel Fink, a la doctora Juanita Romero Díaz y al profesor Wallace. Esperamos que todos ustedes disfruten mucho de esta sesión.
Hello, my name is Axel Fink. I am a professor of rheumatology and epidemiology in Geneva, Switzerland. and I was asked to give a talk about the dangers of COVID-19 infection in patients with systemic inflammatory rheumatic diseases. Now, COVID-19 is a huge topic, and obviously, as a rheumatologist, we are all interested by the fact that many of our medications are used in treatment for the severe forms of COVID-19, in particular glucocorticoids, anti-IL-6, anti-IL-1 drugs, but even JAK inhibitors or hydroxychloroquine have been or are being tried in the early phases of the disease. This is not my topic today. But I will be treating only two topics. One is relating to the risk of COVID-19 infection in patients with inflammatory rheumatic diseases, and answering the question, are our patients at an increased risk of getting an infection with SARS-CoV-2? The same question I want to discuss is the risk of severe infection, namely hospitalization, pneumonia, viral pneumonia, or death related to COVID-19 in our patients. This is in French, sorry, but here, probably as in Mexico, patients with immunosuppression or with immunomediated diseases have been declared at particular risk for this disease. And what I want to do in the next section is explore a bit where this is coming from and whether that is reasonable. It could be viewed as surprising that immune suppression was judged by many health authorities as a risk factor for the disease, as in the very early presentations that we got from China, never were patients on immunosuppressive treatments or patients with autoimmune conditions listed among the conditions that increase the risk. Here, the early presentation of patients from Wuhan, and while you see obesity, diabetes, chronic obstructive disease, etc., cardiovascular disease are listed among risk factors, certainly our types of disease are not appearing in that list. The reason why immunocompromised states were listed among the risk factors for this viral infection probably comes from notions we had from influenza, the regular seasonal influenza infection, where the fact of having a pre-existing immunosuppressed disease does increase substantially the case fatality rate from roughly 0.0% in the general population to up to 23%. And other immunomediated conditions, or such as pregnancy, etc., are significant risk factors for influenza. So it's not surprising that somehow health authorities thought this is a virus, we probably treat it as we do for influenza. I will now present you a couple of studies which I hope will help us have an idea whether patients with rheumatic diseases and inflammatory conditions are really at increased risk of getting COVID-19 or not. This is one of the very early publications from Monti in Italy, where she analyzed a cohort of patients from northern Italy, mostly women, average age 54, mainly RA patients. And of that cohort, 1% of patients developed PCR confirmed COVID-19. Another 1% developed milder symptoms that were highly suggestive of COVID-19. And they had 5 patients that were in contact with COVID-19 diseased patients, but did not develop symptoms. And they didn't see any serious evolution, while all these patients were on biologics or JAK inhibitors. And so they didn't see any favorable evolutions. later publications from that same area, northern Italy, actually reported a bit more serious conditions. This is a publication from Brescia, this is northern Italy, 1,500 patients followed, and by May 1st, 8% or 120 of these patients had confirmed COVID-19. Of these 120, 12 died. And similar data from patients with psoriasis, arthritis, or psoriasis actually reported similar information, and they were able to compute a relative risk or odds ratio of developing a COVID-19 over time, and the odds ratio of developing COVID-19 was around 3 to 4. This is for psoriasis. These are patients that are obese and probably have other metabolic conditions that may put them at high risk compared to people that have purely rheumatoid arthritis or other rheumatic diseases. This is another study from China, another hotspot for COVID-19. And this is an interesting design. What the authors basically did, they looked at the amount of COVID-19 infection within families. And so they compared patients with autoimmune rheumatic diseases and compared whether these had a higher rate of COVID-19 infection if a family member living in the same household had the disease. And the household infection rate was 63% if you had an inflammatory rheumatic disease compared to 34% if you did not have that condition. And so the conclusion of that interesting paper was that patients with rheumatic diseases might be more susceptible to COVID-19 than the general population. And roughly you can see 63 to 34%. It's close to doubling of incidence if this holds true. This is another study from another hotspot of COVID-19. This was from Madrid, where they followed 3,600 patients with inflammatory rheumatic disease, IRD, over time. They analyzed the hospital admission rates related to COVID-19, found 54 of their patients, so this is 1.4%, or an incidence rate of 9 per 1,000 patient months. Compared to the general population in that particular area, the incidence rate ratio for IRD compared to that general population is about fourfold higher than the general population. To conclude this first section, where we are asking ourselves the question, are our patients at an increased risk of developing COVID-19? I think what we can tell so far is that while our diseases, IRD, don't seem to be among these health conditions associated with a much higher incidence of COVID-19, I think we do have some relatively weak indications so far that our population is indeed at slightly increased risk of getting COVID-19 compared to an age and sex matched general population. In the second part of my presentation, I want to examine whether our patients with inflammatory rheumatic diseases are at increased risk of a severe infection or a severe evolution of COVID-19 compared to a comparable population. I am again going to examine different publications from different areas around the world to try to answer this question. This is a very first report from the international collaboration or the COVID-19 Global Rheumatology Alliance, which is a continuous case report of patients with rheumatic diseases who developed COVID-19. They were able to gather 600 patients, half of them were hospitalized, 9% of them died, and they come from more than 40 different countries. Most of them are conventional DMARDs, and the main result of interest for me was that moderate to high dose of glucocorticoids, so more than 10 milligrams a day, was associated with a higher risk of hospitalization for COVID-19. This will be confirmed in many other publications that I'm going to show. However, they were not able to confirm that biologic therapies, NSAIDs, or antimalarial drugs like hydroxychloroquine were associated either with a higher or lower risk of hospitalization for COVID-19. This is only spontaneously declared cases, and we do not know what is the true denominator and what is the population of origin, which is a limitation of this kind of analysis. This study comes from England, where the authors retrospectively analyzed 17 million English patients that are followed via electronic patient records. And the primary outcome was hospitalized death with confirmed COVID-19. And they were able to analyze 5,683 deaths that were attributed to COVID-19. You can see the results, and they're interesting in that we see that rheumatoid arthritis, lupus, and psoriasis, they were grouped together, had about a 20% increased risk of COVID-19 death. This is much lower than, for example, obesity or age, but it is a measurable increase in risk of death. They also grouped other immunosuppressive conditions. So this could be transplantation, other immunocompromising diseases like vasculitis and others, or cancer treatments. And in these conditions, the risk was even higher, with about 70% increased risk of dying from COVID-19. I think this is a pretty strong study, given that the large numbers that we had available. The UK is the country in Europe that has the highest proportion of COVID-19 of the whole continent, so it's relevant. This study comes from another hotspot for COVID-19, namely the East Coast of the US. It's a cohort study that was matched with patients from the general population. The authors found that patients with rheumatic diseases required hospitalization or died with about the similar frequency than the general population or patients without rheumatic diseases. However, patients with RMDs required more often intensive care or mechanical ventilation. You can see the numbers, 48% compared to 7 or 18%, which gives an odds ratio of around 3. Strangely enough, mortality was similar between these two groups, perhaps just a matter of time before people that were in intensive care eventually died. I think this study still suggests that patients with RMDs might have or tend to have a more severe course of the disease. Now, this is a study from Mexico. Indeed, this is available as a non-reviewed paper so far. The data come from the Mexican Ministry of Health. I won't try to pronounce, or I will try, Secretaría de Salud, from the Mexican government. So they were analyzing the risk for hospitalization and for dying of COVID-19. The risk factors identified resemble those that were found everywhere else, namely male sex as a risk factor, increasing age, and comorbidities such as hypertension, obesity, and diabetes. However, given the very large sample size, they were also able to analyze patients that were immunosuppressed. 2% of the whole population was immunosuppressed, and this allowed to compute the relative risk of dying from COVID-19, which was 70% higher compared to patients who were not immunosuppressed. Again, an indication that our patient population may be at an increased risk of a severe evolution, even though in this cohort we do not know exactly what constituted the immunosuppressed patient group. Was it mainly patients with cancer and chemotherapy, or were these patients with autoimmune conditions? This is another study from Spain. If I'm not mistaken, it's from the area of Madrid. And the authors analyzed the prevalence of PCR-confirmed COVID-19 in patients, in a cohort of patients with chronic inflammatory and autoimmune rheumatic diseases. We were able to analyze which condition was associated with an increased risk. On the right side, you see the figure, 0.58. The first column was the reference prevalence in the general population. And as you can see, chronic arthritis, rheumatoid arthritis, psoriatic arthritis, SLE, all had pretty similar incidence or prevalence of COVID-19 compared to the reference population. Some other conditions, however, had a much higher prevalence, and that would be, for example, PMR. It's associated with corticotherapy, glucocorticoids, but also certain connective tissue diseases such as scleroderma or other connective tissue vasculitis, etc. The hospitalization was increased with certain drugs, and they were able to show that JAK inhibitors or biologics had an increased risk of 1.6, and they did not find this increased risk with conventional DMARDs. They were not able, or they did not look at specific biologic agents in this publication. Now, the type of biologics that people receive may matter. There are a number of case reports and case series in the literature. These come from Annals of Rheumatic Diseases, suggesting that some drugs are maybe protective. And here we got several case series from patients on TNF-alpha that suggest a mild form of the disease while on anti-TNF. And these authors in general suggest that anti-TNF may have a protective effect on the evolution to more severe forms and may prevent the severe forms by protecting against high levels of cytokines in the later stages of the disease. Now, the opposite also exists. There are a couple of publications, I show two here, that suggest that drugs like rituximab, by opposition, may actually be associated with higher risk of severe evolution. These authors in Germany report 2 cases of lethal evolutions of COVID-19 on rituximab, and the authors go as far as to suggest preventive measure for patients on rituximab therapy. They suggest that all patients on rituximab should perform SARS-CoV tests prior to getting the drug, that we should consider reducing the dose of glucocorticoids, and to instruct patients to strictly follow the preventive measures after they receive rituximab. Similar results here suggested from the US below. Without going into too much detail, I just want to share with you an ongoing project and some preliminary results from the Swiss registry. We believe that registries are the optimal tool to analyze this kind of infections and the evolution of the disease, because we do have a nice denominator. And so what we do currently is to analyze the incidence rate of mild forms, asymptomatic forms by serology, severe forms and lethal forms of the disease in the whole population of the registry, which is fairly large. So this is depicted here with the waves representing the various incidences of COVID-19. Let me just show you one preliminary result. We looked at patients that received either rituximab or infliximab over the last 6 months and compared the incidence of COVID-19 in these two groups. As you could guess, the two populations are not exactly the same. Rituximab treated patients tended to be slightly older, and they more often were treated for rheumatoid arthritis compared to patients on infliximab. During follow-up, we found 3 cases of PCR-confirmed COVID-19 in this one monocentric analysis. And when we looked at the incidence of severe COVID-19, we had no cases on infliximab compared to 3 cases on, actually all 3 cases on rituximab had a severe evolution, which gives a statistically significant difference in the incidence rate between these two drugs. The details are below in French. Perhaps the one striking thing is that apart from past tobacco use, none of these patients had many comorbidities, and 2 of them died. So how has this evidence been evaluated by our scientific societies? Let's quickly have a look at some of the recommendations that are out there. So these are EULAR recommendations. You probably barely can read it, so let me do read a few of them that I found interesting. EULAR states that there is no evidence for the moment that patients with RMDs face more risk of contracting SARS-CoV-2 than individuals without RMD. This is what they said. I think the evidence may be changing quickly. I was personally quite impressed by some of these studies from China, for example, that suggest that the risk might actually be slightly higher. Then I want to look at recommendation 3. Patients with RMDs who do not have suspected or confirmed COVID-19 should be advised to continue their treatment. This seems reasonable. Perhaps if we have patients on glucocorticoids, I would tend to push to reduce the amount of prednisone pretty aggressively. I personally try to postpone rituximab for the moment. Sometimes it's not possible, in which case I try to give the minimum amount of glucocorticoids and to try to convince patients to be very careful not to get the disease. Then recommendation 7, patients with RMDs without COVID-19 symptoms who have been in contact with SARS-CoV-2 positive persons should be tested for SARS-CoV-2 themselves. So they recommend pretty aggressive screening. This is not always possible, but it's interesting because it's probably not what is being done currently in most parts of the world. ACR has actually pretty similar recommendations. They suggest that the risk of poor outcomes to COVID-19 appears to be primarily related to the general risk factors such as age or comorbidity. This is certainly true that these factors weigh more heavily on the prognosis than having or not a rheumatic condition. And then I just read the guidance statement: ongoing treatments in patients with stable rheumatic diseases, and the whole list should be continued. I personally, as mentioned before, I'm a bit more careful with glucocorticoids and rituximab. These are the other recommendations from ACR. So patients who are well controlled under their current treatment should continue these. However, patients who have been exposed to SARS-CoV-2, they should continue non-immunosuppressive drugs such as hydroxychloroquine, etc. However, immunosuppressants, non-IL-6 biologics and JAK inhibitors should be stopped temporarily pending negative test result. So this is what was recommended by ACR for patients who have developed COVID-19. Patients should consider stopping their immunosuppressants, but they could continue hydroxychloroquine, sulfasalazine, methotrexate, or leflunomide, the conventional DMARDs. For patients with severe respiratory symptoms, they recommend stopping NSAIDs. So what can we make of these various publications? As mentioned to the first question, I think whether COVID-19 infection is more frequent in our patient population, there is some fairly weak evidence that this might be the case, but probably the effect size or the relative risk is not very high, meaning that people may get infected slightly more, but not as much as with diabetes or obesity. Is the risk of severe infection increased in our patient population? There is, I think, a fairly consistent finding in recent publication that we do see more severe evolutions and deaths in our patient population compared to the general population. This is associated probably with specific diseases. Apparently PMR or certain forms of vasculitis seem to be at high risk in patients with rheumatoid arthritis, psoriatic arthritis, or lupus. And it's also associated with specific drugs, in particular prednisone of higher than 10 milligrams per day. And perhaps, I think it's not formally established, but there are a number of reports suggesting that recent administration of rituximab is associated with an increased risk of unfavorable evolutions of COVID-19.
Buenas noches a todos. Agradezco la invitación del Colegio Mexicano de Reumatología para hablar con ustedes sobre las expectativas e implicaciones en los pacientes con lupus eritematoso sistémico ante la nueva pandemia del COVID-19. Como es sabido por ustedes, esta pandemia es causada por un virus RNA de cadena sencilla de la familia Coronaviridae, o también conocido como SARS-CoV-2. Este virus tiene alta capacidad de transmisión, lo cual ha resultado en una nueva pandemia con casos graves de infección respiratoria grave y algunas veces letal. La enfermedad conocida como COVID-19 causa infección grave en adultos, sobre todo aquellos de edad avanzada, aunque individuos jóvenes también se han identificado presentando graves y evoluciones letales de la infección. Cada vez existe más información de la presentación multisistémica de esta infección y los análisis de datos disponibles sugiere que los pacientes con enfermedades crónicas como diabetes, enfermedad cardiovascular y obesidad tienen un riesgo particular aumentado de presentar un curso más grave por la infección. Los datos sobre el curso clínico de nuestros pacientes con enfermedades reumáticas es aún escaso. Actualmente se realizan diversos esfuerzos, entre ellos el realizado por el Global Rheumatology Alliance y el grupo de Leular. Hablando un poco sobre el lupus eritematoso sistémico, esta también es una enfermedad autoinmune multisistémica crónica, con evoluciones que pueden ser también potencialmente fatales. La presentación clínica es muy heterogénea, presentando manifestaciones clínicas o variando desde manifestaciones clínicas muy leves y que cursa con periodos de exacerbación y remisión. Está caracterizada por generar daño tisular en el sitio de depósito de múltiples complejos por antígeno anticuerpo. El tratamiento de lupus eritematoso está basado principalmente por corticosteroides e inmunosupresores durante las fases de exacerbación y durante la fase de mantenimiento con inmunosupresores también. Desde el principio de la pandemia surgieron varias preguntas sobre cuál podría ser la susceptibilidad de nuestros pacientes con lupus eritematoso. Y en sus inicios se pensó que ellos tendrían un riesgo aumentado de adquirir la infección grave por COVID, y sobre todo determinado por el tratamiento inmunosupresor, comorbilidades que los pacientes con lupus pueden desarrollar durante el curso de la enfermedad y también durante los periodos de actividad de la enfermedad. Estas estimaciones se sustentaron todavía más con uno de los artículos interesantes que surgió sobre el riesgo de adquirir las infecciones en los pacientes con lupus. Se encontró que los pacientes con lupus tienen una mayor cantidad de linfocitos TSD8-CD38, lo cual les confiere una mayor predisposición o riesgo para el desarrollo de infecciones. Por otro lado, en un estudio del doctor Wallace, muestra cómo el gen que codifica para la enzima convertidora de angiotensina, la cual es el sitio de unión para el SARS-CoV-2, se encuentra desmetilado y sobreexpresado en los pacientes con lupus. Por tanto, se puede especular que si un paciente con lupus se reactiva, podría presentar una mayor cantidad de este receptor por enzima convertidora de angiotensina y entonces darle una mayor susceptibilidad para la presentación del COVID. Con esto en mente, las conclusiones emitidas hasta mayo del 2020 estimaban que los pacientes con enfermedades autoinmunes o inmunosuprimidos parecían tener factores de riesgo para presentaciones graves del COVID-19. Sin embargo, el conocimiento hasta ese momento sobre la inmunopatología del COVID-19 era limitado para emitir conclusiones definitivas. Pero veamos qué es lo que está ocurriendo con nuestra población a nivel nacional. En un reporte reciente se integró toda la información clínica y epidemiológica del Registro Nacional de Pacientes con Infección por COVID-19. Varios de los hallazgos correlacionan muy bien con lo observado en las distintas poblaciones a nivel mundial, como el predominio de hombres entre ellos y observando que las comorbilidades más comunes fueron la diabetes, hipertensión y obesidad. Pero vean ustedes, el porcentaje de pacientes con COVID-19 y que de base tenían algún tipo de inmunosupresión, únicamente representa el 1.9% de este registro. Entonces uno se puede preguntar, ¿es esto debido a alguna relación con la enfermedad de base? O bien, si simplemente los pacientes con alguna condición de inmunosupresión, al tener o al estar expuestos al tratamiento inmunosupresor, tienen mucho más afianzados todas las medidas de higiene que se han fomentado constantemente durante la pandemia. Una observación interesante. Siguiendo un poco esa observación, veamos cuáles son las diferencias y similitudes que existen entre los pacientes con COVID-19 y los pacientes con lupus. Definitivamente los pacientes con lupus suelen ser de una edad más joven. Aquí tenemos una preponderancia de mujeres, a diferencia de los pacientes con COVID-19, que más del 60% son hombres, e incluso en los pacientes hospitalizados esto puede alcanzar hasta el 80%. Respecto a la obesidad, ha sido de manera reiterada observar que los pacientes con lupus rara vez tienen una alta frecuencia de obesidad. Generalmente el índice de masa corporal de estos pacientes es menor y la prevalencia de comorbilidades, si bien es alta, es mucho menor de aquellos observados en los pacientes con COVID. Comparten entre ellos la frecuencia o prevalencia de hipertensión y posiblemente de enfermedad cardiovascular, pero en menor frecuencia tienen diabetes los pacientes con lupus. También existen algunas similitudes entre ambos padecimientos. Por ejemplo, ambos tienen esta presentación clínica variable desde fenotipos muy leves hasta presentaciones muy graves. La presentación multisistémica o multiorgánica, e incluso ambos pueden desarrollar en algunos o generar en algunos de los pacientes falla renal aguda. Existe desde las evidencias, desde las primeras reportes de esta enfermedad, de la frecuencia del síndrome de activación macrofágica, que podemos ver en ambos padecimientos, pero incluso en COVID esto puede ser de una mayor intensidad, llevando a lo que se ha conocido como tormenta de citocinas. Otra de las manifestaciones observadas desde los primeros meses de la epidemia es que los pacientes con COVID-19 tienen también un riesgo aumentado de desarrollar coagulopatía. Hay algunos reportes donde se ha identificado que puede haber también una mayor prevalencia o mayor frecuencia de la presencia de coagulante lúpico en los pacientes con COVID-19 en ausencia de enfermedad autoinmune previa. Por otro lado, se ha encontrado también que ellos comparten esta mayor respuesta de los interferones tipo 1. E incluso se ha llegado a hipotetizar que los pacientes con lupus eritematoso, al tener sobreexpresados los interferones tipo 1, podrían tener cierta disminución en el riesgo de desarrollar como una mayor respuesta ante el COVID-19. Desde el punto de vista serológico, en los pacientes con COVID-19 se ha descrito todo el grupo de citocinas que se encuentran con mayor exacerbación y en especial en las comparaciones que se realizan entre los casos moderados a graves. Y se puede identificar que el receptor de IL-2, IL-6, IL-10 y factor de necrosis tumoral son aquellos que alcanzan a identificar o diferenciar entre los casos moderados a graves. Dos de ellas son también de las citocinas observadas en los pacientes con lupus eritematoso, como la IL-10 e IL-6. Sin embargo, desde el punto de vista inmunogenético, se ha observado que estos pacientes con lupus eritematoso sistémico puedan tener una mayor expresión en el gen, la enzima convertidora de angiotensina, lo cual es importante para el sitio de unión del COVID-19. Esto generaría un mayor estrés oxidativo y un mayor riesgo de reactivación de lupus, llevando a la disminución en la metilación del DNA y generando la posibilidad o el riesgo de adquirir COVID. Revisando hasta el momento actual, hasta julio del 2020, y en comunicación con diversos compañeros que llevan cohortes de pacientes con lupus eritematoso en diferentes partes del mundo, es interesante conocer que hasta el momento realmente no han visto una gran cantidad de pacientes con lupus y COVID-19 como se esperaba en los primeros meses, lo cual es muy agradable conocer, pero siempre tomando en cuenta y estar cerca con mucha cautela de los resultados que se tienen hasta el momento. Por ejemplo, en la cohorte de lupus de la Universidad de Chicago únicamente se han observado 2 pacientes y estos son de origen afroamericano también con condiciones de hacinamiento y de bajos niveles de higiene que son los observados por la doctora Ramsey Goldman. En Francia, con la doctora Nathalie, realmente, a pesar de tener una gran cantidad de pacientes ya registrados en su cohorte, únicamente 2 de ellos han desarrollado COVID-19, pero fueron también de tratamiento ambulatorio. Y en Corea, con el doctor Bae, en realidad de todos sus pacientes, él no ha identificado uno solo con COVID-19 y con lupus eritematoso. A nivel mundial y en el registro global de pacientes con enfermedades reumáticas, a mayo del 2020 se tenían identificados 600 pacientes con enfermedades reumáticas, de los cuales solo 85, que representan el 14%, correspondían a pacientes con lupus eritematoso. Lo que se puede identificar aquí en estos 85 pacientes es que la mayor parte de ellos se encontraban en remisión. Las comorbilidades asociadas son similares a las observadas en la población general: la presencia de hipertensión arterial sistémica, diabetes tipo 2 y alguna condición que genere enfermedad pulmonar. Los principales factores de riesgo para hospitalización fueron la edad avanzada, el uso de esteroides al momento de la infección, las comorbilidades presentes, y al menos hasta este momento no se identificó ningún tratamiento específico como factor de riesgo para el desarrollo de COVID-19. Asimismo, los pacientes con lupus y COVID, la mayor parte de ellos alcanzaron la recuperación y la hidroxicloroquina no mostró hasta el momento un factor protector para hospitalización. Durante los últimos meses, además, han surgido nuevas preguntas. En muchas de ellas aún no existe la información suficiente para poder responderlas o concluir. Una de ellas es si la etnicidad en los pacientes con lupus antes de adquirir COVID-19, no existe información suficiente para responder. De las observaciones se puede identificar que en las cohortes internacionales se identifica mayor vulnerabilidad en pacientes de origen afroamericano e hispano-latino, pero en mi opinión debe tenerse cautela en este resultado, ya que los pacientes afroamericanos e hispano-latinos tienen una mayor probabilidad, debido al nivel económico menor, de tener limitaciones para el acceso de salud a servicios de salud y sanitización, lo cual les podría dar también mayor riesgo de adquirir la enfermedad. La mayoría de ellos, sobre todo los hispanos latinos de Estados Unidos y pues aquí en varias ciudades de la Ciudad de México y del país, se vive en hacinamiento con mayor riesgo de posibilidad de contagio. Y respecto a la enfermedad, estas pueden tener presentaciones más graves de la enfermedad tanto en hispanos como en afroamericanos, lo cual les predispone a estar en un mayor uso de córticos y mayor riesgo de adquirir la enfermedad. El tratamiento inmunosupresor les protege para el COVID-19. Cada vez existen más preguntas al respecto. Yo creo que no hay datos suficientes para responder esta pregunta. Si bien entre los pacientes con lupus y COVID-19 comparten algunas de la fisiopatogenia o de las manifestaciones clínicas de la enfermedad, el decir que un inmunosupresor les pueda proteger es aún muy arriesgado de poder sustentar. Asimismo, existen diversas inquietudes ahora sobre el perfil de seguridad de la hidroxicloroquina entre los pacientes con lupus. Esto ha sido emanado de los diversos reportes observados de los pacientes con COVID-19 en quienes se utilizó la hidroxicloroquina como parte del tratamiento inicial. Es importante comentar que no existe duda del efecto benéfico de los pacientes con lupus eritematoso. Y es conveniente recordar que el COVID-19 fue distinto porque representa un espectro clínico distinto. El ambiente inflamatorio es muy grave y la hidroxicloroquina se usó en combinación con otros fármacos que potencian su toxicidad, como la citromicina. Por esta razón, el 4 de julio de 2020, la Organización Mundial de la Salud emitió un comunicado para detener todos los grupos de tratamiento de la COVID-19 con hidroxicloroquina. Reportó que, de acuerdo con los resultados provisionales, ni la hidroxicloroquina ni los antivirales que se habían utilizado reducían la mortalidad de los pacientes, los enfermos de COVID-19 hospitalizados. O bien era una respuesta a una disminución muy leve que no soportaba el mantenimiento de estos medicamentos. Por tanto, se decidió la interrupción total de los ensayos clínicos en el ensayo Solidaridad. Por último, se tiene también la inquietud de saber si una vez que se tengan las vacunas disponibles, estas podrán aplicarse a los pacientes con lupus. Realmente no existe todavía la respuesta. Esta va a depender de la naturaleza de la vacuna. Hasta el momento se encuentran en producción una gran cantidad de vacunas, 23 de ellas en fase clínica, 140 en evaluación preclínica. Les muestro a continuación el registro de los 23, al menos de las 23 vacunas candidatas en evaluación clínica que se encuentran más avanzadas. Una de ellas fue publicada hace 2 días, la que es producida por AstraZeneca y la Universidad de Oxford, en donde se han encontrado resultados prometedores, pero aún falta ampliar todos los estudios clínicos para determinar si va a generar la protección contra el COVID-19. Por tanto, ¿qué es lo que podemos concluir hasta el momento? Durante la actual pandemia del COVID-19, las medidas estrictas de distanciamiento social siguen siendo las mejores medidas para contrarrestar la exposición de los pacientes con lupus a la infección por COVID-19. El registro de pacientes con lupus infectados por COVID-19 es menor que el esperado cuando se iniciaba la pandemia, en el que pensábamos que podrían tener un mayor riesgo, pero creo que estos datos deben tomarse con cautela. Es probable que los pacientes hayan seguido adecuadamente todas las medidas de confinamiento y de higiene para prevenir el contagio con la enfermedad. Y posiblemente en el momento en el que se abran más las posibilidades de convivencia, puedan tener mayor riesgo de adquirir el COVID. Es importante reforzar en los pacientes, continuar con todas las medidas de confinamiento para tratar de disminuir el riesgo de adquirir la infección. Creo que por el momento uno de los principales riesgos es el de las complicaciones por las reactivaciones graves del enfermo. El mismo confinamiento ha limitado la posibilidad de atenderlos tanto de manera ambulatoria como a nivel hospitalario. Y no se han podido reconocer reactivaciones graves de la enfermedad. Varios de los pacientes, al menos en la consulta telefónica que tenemos en el instituto, nos hemos podido informar que algunos de ellos ya fallecieron por complicaciones de reactivación grave o comorbilidades que ya traían por el COVID. Por tanto, es muy importante mantener la comunicación estrecha a través de medios telefónicos o virtuales que nos permitan mantener el contacto directo y estrecho con los pacientes. Respecto a la evidencia sobre el riesgo o protección de los pacientes con lupus ante el COVID-19, en mi opinión, creo que aún es insuficiente. Existen algunas hipótesis, como les mostré, en el que se sugiere que la fisiopatogenia de la enfermedad podría darle cierta posibilidad a los pacientes con lupus de tener una mejor respuesta ante el COVID-19. Sin embargo, otras de ellas apuntan a que esos mismos mecanismos podrían darle el riesgo de tener COVID-19 en presentaciones más graves. La realidad es que hasta el momento se han visto pocos pacientes con manifestaciones graves con COVID-19 y que la mayoría de ellos se han recuperado, pero posiblemente esto sea asociado a los buenos cuidados y las medidas de higiene que los pacientes inmunosuprimidos o los pacientes reumáticos están familiarizados con realizar como parte de su vida cotidiana. Diversos grupos de reumatólogos sugieren limitar las visitas presenciales a la consulta solo para los casos activos que pudiesen requerir cambios en el tratamiento. Lo que es cierto es que la pandemia del COVID-19 está generando cambios en el abordaje clínico y manejo y nos está llevando a la posibilidad de mejorar esas formas de atención a distancia con telemedicina o de manera virtual, ya sea de manera virtual o telefónica. Por último, la posibilidad de usar una vacuna en nuestros pacientes finalmente dependerá de la naturaleza de la vacuna, ya que si estas son producidas con virus vivos atenuados, tendremos limitaciones para aplicarlos. Muchas gracias.
Thank you for the invitation to speak with you today. I'm pleased to share our experience at the COVID-19 Global Rheumatology Alliance with you. I'm Zach Wallace, a member of the GRA Steering Committee. I'm a rheumatologist and clinical researcher at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts, in the United States. Here are my personal disclosures, as well as the disclosures from the Global Rheumatology Alliance. The GRA is pleased to receive some support from Amgen, BMS, GSK, AbbVie, and Janssen to help support the work that we do. Today, I'd like to cover a lot of ground with you. I'll begin by briefly reviewing the global impact of the COVID-19 pandemic, and then we'll turn to a discussion of what the GRA does and the data that it has produced today. So we'll talk about the physician-reported registry, literature reviews that are being led by the GRA, the patient-reported registry, as well as future steps that you can expect to see in the next coming months and years. As of July 17th, the COVID-19 pandemic has led to infections of nearly 14 million people worldwide and led to nearly 600,000 deaths. As you can see from this figure, though the pandemic began in China, the real epicenter of the disease has shifted around the globe since then. The virus continues to cause new outbreaks, and with no vaccine or highly effective treatment available, it is expected to continue to cause an increasing number of infections and deaths. From the beginning, it has been clear that the COVID-19 pandemic would have a major impact on rheumatologists and their patients. First, the risk of COVID-19 infection in patients with rheumatic diseases remains poorly understood, but we are learning more each day. Of course, we are all concerned that immunosuppression may increase the risk of infection, but we also know that many of the medicines we use to treat rheumatic diseases, particularly our biologic DMARDs like tocilizumab, anakinra, and others, are being studied as potential treatments for the intense inflammatory syndrome precipitated by COVID-19 infection. Second, the pandemic forced a sudden switch for many from in-person visits to telemedicine visits, which has certainly impacted the practice of rheumatology. Third, early interest in several rheumatic disease medications, particularly hydroxychloroquine, led to drug shortages around the world. Fourth, we are now beginning to see some rheumatic conditions, such as Kawasaki syndrome, as sequelae of COVID-19. And fifth, in the US in particular, the economic impact of the pandemic has led millions of Americans to lose their health insurance. Because of the widespread impact that COVID-19 was expected and has had on rheumatology patients and providers, the Global Rheumatology Alliance was established. Interestingly enough, the idea of the GRA actually began on Twitter as a discussion among rheumatologists about collecting data to better understand outcomes of COVID-19 infection in patients with rheumatic diseases. This quickly evolved an interest group. The GRA was formed and established an organizational structure to guide the efforts of over 400 members, including rheumatologists, trainees, and patients. Today, over 300 organizations endorse and support our work, including yours. We are indebted to all for their tremendous support from the beginning. The GRA is supported by the American College of Rheumatology, of which it is a section, and also by the European League Against Rheumatism. The mission of the GRA is to collect, analyze, and disseminate information about COVID-19 and rheumatology to patients, physicians, and other relevant groups to improve the care of patients with rheumatic diseases during this unprecedented time. Our vision is that by bringing together the global rheumatology community to curate and disseminate accurate and comprehensive knowledge to advance rheumatology care in the COVID-19 pandemic, we can really improve things for everyone. The GRA has 5 main ongoing efforts. First is the GRA Physician-Reported Registry, which we'll talk about. Second is the Patient-Reported Registry, or the Patient Experience Survey. Third is the literature reviews that we have done to help us better understand the impact of treatments on patients with rheumatic disease who have COVID-19 or at risk. We've also lay summaries of the literature so that everyone in the rheumatology community, including patients, has access to the data that we're generating. And we're also developing new surveys to understand the experience of trainees during the pandemic, as well as the experience of patients and providers using telemedicine during the pandemic. The initial impetus to establish the GRA was to collect data on how COVID-19 infections impacted patients with rheumatic diseases. It is amazing to witness how rapidly this registry was started. What began as a conversation only 3 months ago on Twitter evolved over less than 2 weeks into a REDCap survey that went live for rheumatologists to input cases. 1 week later, we had over 100 cases, and shortly thereafter described outcomes in the first 100 patients, and that was published in the Lancet Rheumatology. Quickly, case counts increased, and by May, a little over a month after the registry had begun, we had over 1,000 cases submitted. Today, we have nearly 4,000 cases of COVID-19 infection in patients with rheumatic diseases reported by physicians from around the world. Physicians are able to enter data into a secure REDCap registry. This project has received IRB approval from institutions and organizations around the world. And as you can see from this map, the representation of patients in this registry really comes from around the world, in Europe, Asia, South America, and North America. The first major publication of the GRA was this one, which was recently published in the Annals of the Rheumatic Diseases. In it, we sought to answer the question, what are the risk factors for hospitalization among patients with COVID-19 and a history of rheumatic disease? We used data collected through the GRA Physician-Reported Registry between March 24th and April 20th, 2020. 600 patients were included, and we were able to perform multivariable logistic regression analyses to evaluate risk factors. These are the demographics and disease features of the patients included in the registry. As you can see, we included patients with inflammatory rheumatic diseases, and RA was the most common diagnosis. As with most studies of this population, the majority of patients were women, and the median age was 56. We collected information on common comorbidities such as hypertension, lung disease, diabetes, and others, as well as smoking status. A variety of medications are used by patients included in this registry, including conventional synthetic DMARDs like antimalarials, as well as biologic and targeted synthetic DMARDs. Of the first 600 patients reported in our registry, 46% were hospitalized and 9% died. We identified 3 factors which were associated with a higher odds of requiring hospitalization for a COVID-19 infection. As in the general population, we found that older patients and those with comorbidities were more often required hospitalization. In addition, we found that patients on over 10 milligrams a day of prednisone also seemed to be hospitalized more often. In contrast, those on biologic and targeted DMARDs had a lower odds of requiring hospitalization, which was reassuring and somewhat opposite of what many had expected. As we review this data, however, it is important to keep in mind that this data is susceptible to certain biases, especially unmeasured confounding, which could explain why people on steroids had a higher odds of hospitalization and those taking biologics had a lower odds. However, the data is still very valuable to inform our care and counseling during this time. When we evaluated the association between specific rheumatic diseases and the odds of hospitalization, we did not find that a single disease was associated with hospitalization. However, you can see that there was a strong trend towards lupus patients more often requiring hospitalization compared to patients with rheumatoid arthritis, and this should probably be evaluated in future studies as the size of our cohort increases and we have more power to evaluate this. In addition to the observations I've described, we also found that patients taking hydroxychloroquine for their rheumatic diseases did not appear to have a higher or lower odds of requiring hospitalization. This adds to the evolving body of literature on hydroxychloroquine and COVID-19. This figure on the right is from a recent publication by a number of GRA members in which this dramatic and quick history of interest in hydroxychloroquine for COVID-19 infection is reviewed. With regard to our findings regarding the association between biologic DMARD use and a lower odds of hospitalization, this was strongly driven by the subgroup of patients on TNF inhibitors, as you can see from the reported odds ratio below. So, population of patients, that hospitalizations are common in this population. Risk factors for hospitalization in this population are similar to those that we observed in the general population or have been observed in the general population. In particular, rheumatic disease patients who are older and have other comorbidities seem to be at higher risk of requiring hospitalization when they have COVID-19. Novel risk factors that we identified in this study include corticoid exposure at higher doses, greater than 10 milligrams a day. And interestingly enough, this was also observed in a similar registry of patients who have inflammatory bowel disease. Biologic and targeted DMARDs do not appear to be associated with higher risk of poor outcomes, which is very reassuring. However, we need to interpret this data cautiously. Some of the limitations of this study include selection bias. Patients might be more likely to be reported in this registry if they are more sick or have been hospitalized. There's also the possibility that there remains unmeasured confounding, and the findings here may be less generalizable because of the geography of some of the cases and the areas from which they were reported. But over time, we're hoping to do a lot of work to make sure that our registry really reflects the global experience and ensuring that we have cases reported from around the world. I'd like to highlight some of the other types of studies being done using the physician registry data. In the United States, we have quickly learned that COVID-19 seems to be having a greater impact on racial minority communities. We wondered whether minority patients with rheumatic diseases were also at higher risk for worse outcomes. To answer this question, we used GRA cases reported from the United States between March 24th and May 22nd, 2020. 694 patients were included, and we evaluated the association between race and hospitalization, mechanical ventilation, and death using multivariable logistic regression. The three primary racial groups represented included white, Black, and Latinx patients. As you can see, there were differences in the distribution of rheumatic diseases across these groups, as highlighted in the yellow box towards the top of the table. In particular, Black and Latinx patients more often had lupus than white patients. In addition, the distribution of comorbidities were different across the racial groups, such that Black patients tended to have comorbidities more often, particularly hypertension, cardiovascular disease, diabetes, and renal disease. This is highlighted in the second yellow box in the middle of the table. Again, a variety of medications were used in this cohort, including conventional DMARDs as well as biologic and targeted DMARDs. There were patients using a variety of doses of glucocorticoids And we didn't talk about this before, but we captured people with a variety of disease activity from their rheumatic disease, ranging from those in remission to those having high disease activity. With regard to the primary outcome, we found that Black and Latinx patients in particular had a higher odds of requiring hospitalization or ventilation because of COVID-19 when compared to white patients. You can see that Black patients had a threefold higher odds of requiring hospitalization and ventilation. Latinx patients had a twofold higher odds of requiring hospitalization and a threefold higher odds of requiring ventilation compared to white patients. The odds of death did not appear different across the groups. This should be evaluated further as the number of deaths increases, because still, reassuringly, we have a low number of deaths in our registry. In summary, in this study, we found that racial minorities in the United States had worse outcomes than white patients, and these differences persist after adjustment for comorbidities and other covariates. However, we need to be aware of unmeasured confounding when interpreting these data. There are many potential explanations for these observations, including that these groups may have had more difficulty practicing social distancing, they may have had more limited access to healthcare because of the way healthcare is structured in the United States, and there may also be other socioeconomic factors at play that contribute to these observations. There's also interest in using this data to look at subgroups of patients with rheumatic diseases, and you'll be seeing more analyses like these coming out in the future. In this case series, we sought to understand what the outcomes were following COVID-19 infection in pregnant patients with rheumatic diseases. Cases entered between March 24th and May 22nd were included. 11 patients were included, the majority of whom had lupus. Nearly half had stopped their anti-rheumatic treatment because of COVID-19. Nearly half were hospitalized, but outcomes of those hospitalizations seemed relatively positive. Only one patient required supplemental oxygen. The outcomes of pregnancy are not yet known. So, as you can see from this example, the data from the GRA physician-reported registry is rich with detail and can be used to answer a variety of questions. And towards the end, we'll touch on how you and your colleagues may have an opportunity to use some of this data as well if there's questions that you're interested in answering using it. I'd like to turn now to some of the other types of studies being led by the GRA, including 2 literature reviews which have recently been submitted for publication. The first review, which we'll discuss here, sought to understand what the risk of viral respiratory infections is from commonly used rheumatic disease medications. This was a scoping literature review that identified data from a systematic search of databases and a review of key clinical trials. It was led by 3 GRA members, Adam Killian, Aruni Jayat-Bieki, and Jean Liu. Their team reviewed nearly 10,000 references and included 180 studies in their analysis. Most were observational studies focused on biologic DMARDs, particularly those being used for RA or lupus. This figure captures the number of studies reporting various outcomes. You can see that the most commonly reported outcomes were upper and lower respiratory tract infections. They found that several rheumatic disease medications were possibly associated with higher risk of viral respiratory infection. These included steroids, JAK inhibitors, especially at high doses, TNF inhibitors, IL-17 inhibitors, and leflunomide. In contrast, for other drugs, they did not find a clear association with higher risk of viral respiratory infections. These included NSAIDs, hydroxychloroquine, sulfasalazine, methotrexate, azathioprine, mycophenolate, apremilast, and cyclophosphamide. Their conclusions were that there may be some differences in terms of risk between rheumatic disease medications, but the ability to determine this is limited because of poor reporting of viral respiratory adverse events in studies. I think what this study really highlights is how as a community we need to do a better job of documenting these sorts of events in our clinical trials and in our studies so that we really have a good understanding of the risk when viral pandemics like this occur again, because Unfortunately, I don't think this is the end of viral pandemics in the world. In the future, antibody testing for COVID-19 may be useful for evaluating the risk of the risk of infection with COVID-19 associated with these medications, and we look forward to those studies in the future. The second literature review was led by Ali Duarte and Mike Putman. In this review, the team sought to review the data to determine whether anti-rheumatic disease therapies are effective for COVID-19. As we all know, there's been a lot of interest in many of our medications, including hydroxychloroquine, IL-6 inhibitors, and others, in treating the complications of COVID-19 infection, particularly the sort of systemic inflammatory response that many patients experience. This question is of particular relevance to our community because of the impact that use of these medicines, particularly hydroxychloroquine, has had on access to them. So, to answer the question that this group had, they performed a systematic literature review and meta-analysis. It is remarkable. I mean, both literature review teams have done an incredible job. This team reviewed nearly 4,000 articles that were published between March 19th and May 7th, 2020. I should also highlight that they included articles which had not yet been published or peer-reviewed, but were reported in archives. Or preprint services. They ended up including 45 articles. In addition to summarizing the data from these studies, they were able to perform a meta-analysis of 3 cohort studies of hydroxychloroquine and 2 cohort studies of anakinra. The reason why they could only do the meta-analysis with some of the studies was because they needed to have studies that measured the same exposure and the same outcome in a at least similar patient population. To summarize their key findings, as is becoming increasingly clear, hydroxychloroquine did not appear to be associated with an increased or decreased risk of death or intubation among patients hospitalized with COVID-19. You can see in figure 1A here, this was a meta-analysis of 3 observational studies using hydroxychloroquine, looking at mortality among patients hospitalized. And you can see the hazard ratio overall, including the 3 studies, was 1.4, and the 95% comfortable included 1. In figure 1B, you can see that this is a meta-analysis of 2 observational studies investigating hydroxychloroquine and the composite outcome of death or intubation among patients hospitalized with COVID-19. Again, the hazard ratio was just about 1 in this case, and the comfortable included 1. In contrast, they did observe that there seems to be a signal from 2 observational studies suggesting that anakinra may be associated with a lower risk of death among patients hospitalized with COVID-19. However, this should be interpreted very cautiously. There were 2 studies included. Both had a rather high risk of bias because of the nature of the studies. So we need to be cautious in the way that we interpret this data. Besides anakinra and hydroxychloroquine, they also identified a number of other studies using other drugs, including IL-6 inhibitors, especially tocilizumab. And the conclusions there were that a lot of these studies had significant biases, were somewhat preliminary, and it was hard to make any conclusions. And we continue to await large clinical trials and other large observational studies that have lower risks of bias, and can help us understand the role for these other rheumatic disease medications in the treatment of COVID-19 infection. I'd like to now turn to my last topic in this talk, and that's the GRA patient-reported registry. It's also referred to as the patient experience survey. From the start, the GRA has been lucky and honored to have tremendous involvement by patients living with rheumatic diseases, as well as the parents of children living with rheumatic diseases. Our steering committee includes 2 patients, or 2 patient representatives, which has really enriched the discussion that we have around how best to ask relevant questions that are meaningful to providers and patients during the pandemic. The patients, along with many of our partnering organizations and the providers who are part of the GRA, helped launch the GRA patient-reported registry. The goal of this patient experience survey is to understand the patient experience during the pandemic. This experience includes medication shortages such as hydroxychloroquine, which we know many have experienced, issues with access to care using telemedicine or getting in touch with their rheumatologist. For those who've had COVID-19, their experience with that infection, what symptoms they had, what the outcomes were, and understanding how experience may have varied across different patient groups. This survey is available through a link on our website and can be completed by any patient around the world. As I mentioned, it was developed by a number of patient organizations as well. And so the survey can be accessed from some of their websites, and tried to make sure that if they had their own survey, many of the questions included in patient organization surveys were similar to those that we included in this GRA patient experience survey. Like the GRA physician reported registry, the patient experience survey is an IRB approved study. And I think what's amazing is that because of the incredible community that's come together to form the GRA, we're able to find volunteers to translate the survey into many languages, including Spanish. Currently, over 13,000 patients have completed the survey. A little over 6% of them have had COVID-19. A variety of data elements are collected in the patient experience survey. This includes patient behavior, impacts of the pandemic on patient employment, use of immunosuppression during the pandemic, the ability of patients to connect with their providers during the pandemic, as well as patient-reported outcome measures using the PROMIS database. And many of the data elements that are included in the patient experience survey mirror those included in the physician-reported registry, such as demographics, rheumatic disease diagnosis, medications, comorbidities, and details of COVID-19 diagnoses and treatment if relevant. And the reason why we designed it this way is so that the patient-reported data and the physician-reported cases could be used in complementary ways in future studies. I should highlight that the team working on the patient experience survey has a publication in Arthritis Care and Research sort of describing the development of this survey, the involvement of patients, the involvement of patient organizations, and how social media was harnessed to get such an amazing response from over 13,000 patients who completed the survey. Of the 13,000 patients who've completed the survey, the majority are adults. There's also 5% of the surveys were completed by parents on behalf of children living with rheumatic diseases. As in the provider registry, the majority of patients have rheumatoid arthritis, but a variety of other conditions are represented. Lupus is common. We also see a lot of Sjogren's and ankylosing spondylitis being reported in the patient experience survey. As I mentioned, around 6% have had COVID-19, and about 28% of the cohort was taking hydroxychloroquine at the time of the survey, and 7% of these patients developed COVID-19. So, I think one of the interesting things about our experience at the GRA is that from the beginning, we've been able to influence some of the discussion in the world on COVID-19 and its impact on patients, including patients living with rheumatic diseases. In particular, we've been able to comment and show that while there was a lot of hype around hydroxychloroquine early on, certainly patients taking hydroxychloroquine were getting COVID-19 infections. We were able to demonstrate that very early on. So, as you can see, the GRA has been quite busy during the pandemic and continues to work on more studies to answer questions relevant to rheumatology providers and patients around the world during this unprecedented time. In the future, we'll be launching additional surveys to assess the experience using telemedicine and of trainees during the pandemic. We're starting a literature review looking at the risk of COVID-19 infection in patients with rheumatic diseases. We're evaluating risk factors for death in patients with rheumatic diseases, and also probably starting a longitudinal study of the patient experience. We'll be looking at outcomes among patients with specific diseases or on certain medications as well to better understand the impact of COVID-19 on our community. So how can you learn more? Visit our website, send us an email, either theroomcovid@gmail.com, or you're welcome to email me as well. There's my email address. Please subscribe to our mailing list. We send out updates regularly about the work that we're doing and our findings and what we're publishing. You could follow us on Twitter or on Facebook. Please submit your cases, encourage your patients to share their experience in our patient experience survey if they haven't already. If you visit our website, you can also learn more about opportunities to work with others to analyze the data that we've collected from providers around the world. So I'd like to thank you for your support. I'd like to also acknowledge the rest of the GRA Steering Committee. It's been an amazing opportunity to work with these people from around the world. I'd also like to acknowledge the ACR and ULAR for their support, the patient board, all the patients involved in the GRA, the Clinical Advisory Scientific Committee, which includes rheumatologists and trainees from around the world to do some of the studies and projects that we've talked about today, our corporate sponsors, and finally the UCSF and McMaster data management teams who help us analyze all this data. So thank you very much, and I'm happy to take any questions that you have. Thanks.
you.